As we move to our next panel, which is made up of Mike Waldrum as moderator, Sharrelle Barber, James Johnson, Weyling White, and Reverend Mac Legerton, let's again welcome them and thank our last panel for a wonderful start. Mike.
Thank you. Appreciate it. We're gonna. This panel is called "Place Matters: From Health and Healthcare Disparities to Equity." I first want to start by thanking the National Academies for bringing this discussion to North Carolina, and thank Victor and Mandy for their work in coordinating this, and thank you, Mandy, for your leadership in this state. And I know it has been a tough week, but you are in the choir here, and we, as you've heard, we all are very supportive of your efforts generally and specifically with expansion in this state, which is long overdue. I'm going to start by introducing the panelists who are each going to come to the podium and speak for about 10 to 12 minutes, and then moderate discussion, which is going to include you, and further this discussion. I do want to make an announcement right off the bat as I introduce the panelists that unfortunately Dr. Jim Johnson, who has participated actively in this planning, unfortunately has a health issue and is not able to be here today, and so we're not going to be able to hear his expertise, which is always such rich input, but unfortunately that just gives us a little bit of time, and we'll try to accelerate a little bit. First, I'm going to introduce all the speakers, and then they're going to come up in order, and then we'll have the discussion. Dr. Sharrelle Barber is here from out of state and is the assistant research professor of epidemiology and biostatistics at Drexel University, and will be giving us some national and then local perspectives from an epidemiologic perspective. And then Reverend Mac Legerton is a rural development specialist and nonprofit public sector consultant, and served as the director of the Center for Community Action for 36 years, and is in Southeast North Carolina and a very active community member there, leading a number of important initiatives. And then lastly, we'll hear from Weyling White, who is the practice administrator at the Roanoke Chowan Community Health Center in Ahoskie, North Carolina, and is proud to announce the first African American mayor of Ahoskie, North Carolina. And I just want to give a shout out. We're so proud to have Vidant Health CEO, and I'm so interested in underserved populations, and in Eastern North Carolina, covering 29 counties. But we're so proud of Weyling and the work that he's done at the Community Health Center, which is a partnership with us there, and in this community, and driving many of these issues forward. So we look forward to the discussion.
So thank you so much for the opportunity to be here. So I am based in Philadelphia, Pennsylvania right now, but this is home. And I actually was really excited to see Pam Silberman, who was one of my former professors at UNC. And I am tasked with just kind of grounding us as a social epidemiologist. I think I might be the only one in the room, of grounding us in some of the data and helping us to kind of think a little bit more deeply and critically about why place matters for health and why we need to be thinking about it in this context. And so someone quoted Hippocrates earlier, but I'll say this again. He said something that is ancient. So we know that place matters. It's not a new thing. Tell me what is ailing you, and I will tell you where you are from, right? And so place being fundamental to how we understand health, and also how we understand health inequalities, is really important, and it's not new. And in fact, one of my academic heroes, W.E. Du Bois, in the Philadelphia Negro, also documented at the turn of the 20th century stark inequalities depending on where people live. And I, as a social epidemiologist, have really kind of thought about this at the intersection of place, right? So we know place matters for health for so many of the exposures that have been talked about and discussed today. But we also know that in this country and in this state and in the South in particular, place cannot be understood outside of race and more specifically structural racism, right? And so we cannot talk about place mattering for health without having a serious conversation about how structural racism has created the places that we live and we learn and we work, and how that has implications for racial and economic disparities that we see as it pertains to health. And so I actually want to position the conversation looking at place mattering at 3 different levels. I want us to think about this from a national and regional perspective, and then from a kind of a statewide, and then looking at some of the local communities here in North Carolina. So this is one of the maps that actually got me started in my research, really examining kind of chronic disease outcomes. And this graph is really striking to me, that the South in particular is known as the stroke belt, right? And at Harvard, when I was a doctoral student, someone said, "Oh, that's just race genetics." And I laughed and cringed. But I know it's the legacy of Jim Crow and slavery and things that has created these conditions in the South that are really fundamental to our understanding of health, right? And so in that same class, I did a project on racial discrimination and hypertension, because again, we have to think about how these institutional factors have created the burden of health. And this is stroke, but we see this map for obesity, for coronary heart disease, a wide range of chronic diseases. The South and North Carolina in particular bears the burden of these inequalities, right? We also have been having a large conversation about infant mortality and maternal mortality across the nation. Really thanks to some really powerful women in the reproductive justice space have really talked about the racial inequalities that exist, the striking racial inequalities that exist by infant mortality. And so we know that, Black mothers are 10 times or more likely to die in childbirth compared to their white counterparts, right? And so we see these striking racial inequalities, but again, this also shows up spatially, right? And so in the South, in North Carolina in particular, we have rates of infant mortality and maternal mortality that are much higher than other parts of the nation. And we also know that the racial disparities in these outcomes are also very significant. Everyone said it, but I'll say it again. We have got to think about what are the policies, both within the healthcare system and outside of the healthcare system, that are driving these inequalities. Medicaid expansion, we've got to do it in North Carolina. I'm in Philadelphia, in a state that has expanded Medicaid. We've got to do it here, and we've got to push the needle. We've got to push our legislators to understand that this is a fundamental driver, in some ways, of some of the health outcomes that we see. But again, we know that health occurs so much outside of the healthcare system. And again, I would just ask you to think about what are some of the other policies outside of healthcare that are driving the disparities that we see and the regional kind of geographic dispersion of different health outcomes. So then if we move to North Carolina and we look at Robert Wood Johnson Foundation has this really nice community county health ranking system that they do each year. And here's North Carolina. And again, widespread geographic differences when it comes to health. And these are based on health outcomes, including self-reported health, infant mortality, and other outcomes. What you'll notice here is, what you'll notice, if I can get this to move, we have in the North Carolina our own black belt, right? And we know that in the black belt, that's where we have our worst health outcomes, right? So again, place mattering and race mattering and intersecting to create kind of these conditions in the state of North Carolina. But if you look at the drivers of health, right? So this is things like economics. These are things like health behaviors. Those same drivers of health are also overlaid geographically in the state of North Carolina. And again, go along racial lines as well, geographically in our state. And so these, again, shows the kind of primacy of place in the state of North Carolina specifically. And we see this in terms of life expectancy. So how many of you all travel up 64, Highway 64, right? So there's about on Highway 64 going from Raleigh to Rocky Mount, there's a 7-year difference in life expectancy, right? In the state of, going up this highway. Again, thinking about what are the policies that have created such large gaps over short distances in our state. So my introduction to this idea of place mattering actually happened in Rocky Mount, North Carolina. I was a student at UNC in the health behavior department, and we did a community action-oriented diagnosis, of Southeast Rocky Mount, which is a community that's low incomes, predominantly African American in Rocky Mount. And I'll never forget it. One of the pastors, longtime pastors, community activists in Rocky Mount said, this set of train tracks is symbolic, right? Because it represents the racial, social, economic, and political divide in our community, right? But this set of train tracks is not just Rocky Mount. It's Durham, North Carolina. It's Chapel Hill. It's Greensboro. It's everywhere you go. We see this kind of divide in cities. And we know that it's not just about the separation of people. It's about the separation of resources and the investments or disinvestments that have happened in communities over decades. And so I couch my research and the work that I do in a deep understanding of racial residential segregation. And someone mentioned this earlier today, that we cannot understand place, and particularly place in local communities, without understanding the ways in which federal, state, and local policies created neighborhood environments that we live in today. So in our dialogue around neighborhood, we cannot be ahistorical, and we cannot deny the ways in which institutional and structural racism has created separate and unequal living conditions for folks in our state and around the country. And so redlining map, this is a redlining map actually of Philadelphia. And again, the same places that were redlined back in the 1930s are the same places that are disinvested. But it's not just these redlining maps, right? The way structural racism works is that it finds a way to recreate itself. So we got rid of discrimination in housing in 1968 with the Fair Housing Act. But we still see high levels of residential segregation across the country. And so redlining started the kind of cascade of events, but we still have discriminatory lending practices and other practices that create these separate and unequal environments. And so this is actually a map of Durham, right? And in that kind of southeast corner where Lincoln Health System is, we see that same place being an area that is disinvested to this day, right? So why do I kind of go through this history lesson in my kind of talk about restrictive residential covenants, also talk about racialized violence? We cannot talk about segregation without talking about racialized violence, but it's so critical because, again, it shows that our communities have been segregated not by accident, but by design. And if we can figure out ways to create these inequitable environments, we can figure out ways to recreate these equitable environments through policy and through interventions that actually make communities more equitable and make it so that folks can actually not only survive, but thrive. And so, and we know that segregation is fundamental because of things like schools and jobs and access to healthy foods and all of the resources that are conducive to healthy living, right? And so I often talk, we often kind of harp on the food part, but that's only one of the symptoms of the disinvestment. And so I think in local communities, one of the things that we have to move towards as we're thinking about how do we create more healthy and more equitable communities, think about, yes, access to healthy foods, think about optimizing healthcare systems, but how about investment in jobs? How about investment in education? Those multi-sectoral policies that will actually build up communities on multiple domains and really improve the health of those communities. So I've done work actually for the last 6 or 7 years in Jackson, Mississippi with the Jackson Heart Study. And this is just one data point where we show we have a measure of residential segregation that we use. We look at incidence of cardiovascular disease and stroke over a 10-year period. And what we see in an all African-American sample, okay, is that you have a twofold difference in your likelihood of having a stroke or heart attack depending on the neighborhood that you live in. So change the environment, change the outcomes. And this can happen even among an African-American population, right? So again, getting at that idea that these are structural and fundamental causes of health and health inequalities in our cities and our state. And so finally, I'll just want to just highlight one of the kind of exciting innovations that I see happening in this area of building healthy communities. So the California Endowment has started in 2010 a Building Healthy Communities initiative. And really thinking about places, your zip code is more important than your genetic code in determining health, but thinking about it from a real kind of grassroots and community organizing perspective. So it has 3 tenets. How do we build power in local communities to think about the policies necessary to change the outcomes in our communities, right? So building not just capacity, but power. And this is economic power, political power, et cetera. How do we do that in our local communities? Because the challenges the changes and the transformation that is required is going to require some fundamental changes to our local communities. The other thing is policies and systems changes, right? So what are the set of policies, both within the healthcare system and outside of the healthcare system, that optimize health in local communities, right? So again, it's not just expanding Medicaid. It's not just creating better healthcare systems. How are we improving education in communities? How are we, even when there's development, are we making sure that displacement is not the unintended consequence of that, right? What are we doing in terms of the tax code to make sure that as we develop new, better communities, that everyone is benefiting from those new developments, right? And again, systems changes, right? And so when we think about increasing access to healthy foods, for example, we have to, again, think about it as a part of a system and think about how we not only change the access to healthy foods, but the other types of investment necessary in those communities. And then improving opportunity environments. How are we creating opportunities for children, for adults in their communities, so that, again, that they can live the most optimal and the most healthy lives possible? And so I'll just leave with this. And so we talked about equality. We've talked about equity, but I think we actually need to be moving towards liberation. How do we liberate communities to be able to have and to not only survive and to thrive? And then I'll also just end with a quote from Dr. Mary Bassett. She's a former commissioner of the New York Health Department, and she says, we must name racism as a cause of poor health, because how we frame a problem is inextricable from how we solve it. And in the state of North Carolina, where I'm happy to be born and raised, we've got to address this issue head on if we're really going to move towards health equity in our state. Thank you.
I could have just sat down and let her go. And, that was amazing. So I'm going to talk a little bit similar to some of the things that Sharrelle talked about also, but particularly from my community. So before Mike introduced me, had anybody heard of a hospital in North Carolina before? Really? Wow. Okay. Was it good or bad? Because we know for some bad stuff. Okay. So. Oh yeah, community health center. Okay. So we're going to talk about some disparities, and we can talk about equity as well. This is my frat brother here, along with one of my other frat brothers in the room, being Mike. Got to give him a shout out. This is one of the. This was published in. This quote was from 1966, and 2019. This is still relevant. So I wanted us to start highlighting this right here. All forms of inequality, injustice in healthcare is the most shocking and inhumane. So, Hertford County, North Carolina. Population of 24,000. Sharrelle talked about us being in a belt. We also in a hot spot. So if you looked at our mortality rates for colorectal cancer, we have one of the highest in the nation. Also, leading causes of death is heart disease, cancer, diabetes. That goes right along with us having a high population, a high density of African Americans. And in comparison to North Carolina, we are at 60.5% of our population are Black African Americans. And when you think about disempowerment and disenfranchisement, 2 weeks ago we just had our first Black mayor, 126 years. So that says something in itself. In comparison to North Carolina, some of our rates are lower, some are higher. Some of that we're looking at today is, of course, our birth rate, median household income is lower. Our education attainment rate is lower than in comparison to North Carolina. However, when it comes to poverty, we have a higher rate. And I see Lynn Hollowell is here. Yeah, I'm shouting out people all day, so forgive me. But I wanted to say in regards to insurance coverage, we did have a decrease in our uninsured population through some of the things that we've done in the community. So we are having higher medical coverage in comparison to North Carolina around that. So structural racism. I'm not going to tackle this. Sharrelle did it. So she did an amazing job. But one thing I will say about health equity, you cannot achieve health equity, you cannot address health equity without first acknowledging and being intentional about racial equity in this regard as well. We do know that there's race versus racism. And I don't know if you all are aware, but race is a direct product of racism. Racism came first, and that's why we are all attributed to a particular race, and we know that that is because of superiority. So with that being said, I was going to talk about redlining, but Sharrelle did a good job on that. But what I'm going to do is just talk about how this has impacted my community from a very, very literal sense. So we also was impacted by a railroad track, and guess what? This is 4 blocks from where I currently live. But on this side, we have Ward A. So when we just had our general our elections for municipalities, we had 2 wards, Ward A and Ward B. I live in Ward A now. And one story about this is my grandfather, who I talk about a lot. When he found out I had moved into Ward A, he said, "Hey, got a nice house. You know, when I was coming up, he was a plumber. He went to different houses, crawled under sinks and dig ditches and everything. And he said, if I took a job in Ward A in your yard, I had to make sure I was back across the railroad tracks before sundown, or I would not make it back home." And that wasn't too long ago. So in Ward A, I know you all are pretty familiar with our Waldrum Community Health Center and, of course, Vidant Hospital, all located in Ward A. All of our public schools, our health department, we have a nice amphitheater, our high school recreation center, our vital wellness center, our police station. All of our resources are located in Ward A. In Ward B, we have 3 tobacco shops. We didn't need 1, we need 3. Two are within 20 feet walking distance. So if you come over here, they don't have your particular pack of cigarettes, you could just walk 20 steps and get an option. We also have increased crime. Our infrastructure is diminishing. A large number of funeral homes, and of course, all of our African American churches are located in Ward B. So Ward A, just to give you all a better picture of Ward A, we have an amphitheater. We have a new display with the Hereford County Bears, so we just have that that's been built. We have a dog park and a husky, so if you all are coming to visit, please bring your pets with you, okay? Yeah, I'm very proud about that. I don't own a dog, but I am very proud of that. So we have our hospital and our health center, of course, and in Ward B. So this is part of the reason why I wanted to take action and take a part in my community. This article right here, we just got this in our newspaper 2 days ago. This shooting took place on Sunday. These are buildings this is right off of our main street. At the top, I used to get my hair cut there, and I got that cut in high school. I'm not that old, so you can tell the type of structure this building was in. And this is one of our tobacco shops that I was talking about earlier. Also in this ward, we also, with all of this, we also have a lack of small businesses and healthy food options as well, which we couldn't fit on this slide, but this is just to show you what's going on in that ward. So I see some community health center folks in here, Community Health Center Association. I know you all are aware of what this video is. This is out in the rural. So to give you all a little bit of background of where we are moving towards in our organization at Waldrum Community Health Center, another funny, not a funny story, but I'll tell you, I got a lot of stories. Our CEO, Kim Schwartz, thought that it'd be good for us to get back to our mission. You know that Community Health Center started out of the civil rights movement and providing civil rights to those that were in poverty. And so we thought it'd be a really good idea to show this to all of our staff in the organization. And I showed it, I did a site meeting, and after that meeting, I was confronted with a lot of criticism and backlash because this particular video showed a lot of black nurses, black providers giving care to black patients in a very rural town that was very poor, which sounds a lot like a hospital, right? So we said, okay, now if our people that are delivering care are having these feelings about our mission that's tied directly to our organization, we have a huge problem, correct? We have to address this. So we decided that we need to tackle health equity. We need to be very serious about this. We pulled the health equity definition. These are 3 different definitions, and so we wanted to be very intentional about this work and be very intentional about our stand in our community and at our health center in regards to how we are treating patients. Some of the things that we wanted to do, we started early, so before we actually developed a health equity committee, we had done a SOGI training, which we call SOGI, which was a sexual orientation and gender identity training. In our EPIC system, we had SOGI questions that we would be asking all of our patients, and some of our employees and our staff members were a little bit uncomfortable about asking those questions. So to make sure that we are having the proper education, we developed a resource and a training that we had all of our staff to go into, and we also identified uninsured patients, LGBTQ, and the young adult populations were populations we were going to be focusing on. We reestablished our health literacy committee into the health equity committee in 2017. So some of the initiatives that we wanted to tackle was discounted care and nominal fees. So we decreased our fees so we could have more affordable care for patients, so they can we dropped it down to $15, so patients are paying that now. And we did also extend our hours of operation so that we have a lot of moms that have to work 2 jobs and they get off at 5 o'clock, they can't receive their care. So we extended our hours to 7 so that we can be able to accommodate more people to be able to get those healthcare services that they need. We also implemented interpreter services. And another story that really drives home as to why it's important for us to actually think about health equity in the healthcare delivery role is we actually had a situation where there was a patient that came, and this patient last name was, I think it was Martinez. And the front desk staff person, when the person walked up, they said, "Oh, I need somebody to speak Spanish." And the person said, "Hey, I'm just here for my appointment." They spoke English, but it's that bias that is ingrained in our community. So we have a farm worker health program. We adjusted our living wage in 2016. And the most important thing was we have our governing board adopted the IHI Leadership Alliance Health Equity Call to Action. We are very, very excited about that. Our board is very serious about health equity and intentional about our practices and where we're going as an organization. So our Health Equity Committee, we have 12 members, 3 co-chairs. I'm one of the co-chairs. We meet monthly. We just had our meeting this week, actually. And one of the most important things is we have voluntary membership. So for any organization that's leaving here and say, "Hey, we want to address health equity, we want to be intentional about this," the most important thing is to make sure that you're not forcing anybody to do that or forcing anybody to come around this, because there's a very fine line between voluntold and tokenism. So voluntold is something that we hear a lot, because I get voluntold a lot in my organization. But I will say in this regard, there wasn't any tokenism. So we didn't want to go to anyone in the organization and say, "Hey, we need somebody that's homosexual, so come join our health equity team," or "You're Hispanic, come join our health equity team." No, we're not going to do that. It's only on a voluntary basis. If you are very serious about this, we don't want to have anybody that is the wrong voice coming to the table to address these issues. So we also work with Vidant. So we have Vidant to come aboard, and they did Vidant Empathy Salons in 2018. We had them to come and meet with some of our staff to address empathy. And some of our members went to the racial equity training in Greensboro to learn more about that. We underwent some of the Harvard implicit bias. We looked at identifying disparities in our health outcomes. So we have our quality improvement team that are addressing different chronic diseases and health disparities in our community. And we also are looking to investigate how to decrease these gaps as well. One of the biggest things I wanted to point out was our community partnership, which is Hereford Health Maintenance Alliance. I've been involved in that since 2013. The Duke Endowment has given us grant money to provide access to care for our uninsured population. And with that, we have begun to expand and work on numerous strategic goals and strategic partnerships and strategic plans in our community. One of those has been transportation and addressing social determinants of health. And with transportation, we know that that has been a direct link to people not accessing health care, not being able to live healthier lives. And so we have been able to strategically put together a program that can help patients that can't afford transportation or don't have it to be able to get to the resources that they need. We've also been able to build our community partnerships. So it's not just a lot of medical facilities and medical organizations in the community. We have DSS at the table, Office of Aging, Chowan University, our local community college. Anyone that has an impact on the residents of our community, we bring them to the table through this partnership. So lastly, just some of the things that we're doing for the community. We're just identifying extra steps for each member, focusing on staff diversity. So we are being intentional about our recruiting practices and things around that nature and policies. We're also focusing on pay equity, opportunity equity, and I'm very, very excited about our leadership skill development. Not only are we just being more equitable for our patients and our staff members as well, but we do realize that all of our staff members are not able to access the same skill development as others as well. So or if you work front desk or if you're a medical records or a janitor and you want a class in public speaking, you want to learn how to do resume building or developing an agenda, we're going to be providing those skills in-house at our organization so that we are having equitable opportunities for all of our staff members as well. And we're also partnering with our leadership team to identify topics, teaching, and schedules as well. So that's my time. Thank you all very much.
It's almost afternoon, I guess. So I'll say good midday. It's good to be here today. I particularly want to honor Jessica Marks for her work. Our panel actually had two introductory calls together in planning for this particular panel. And I'm going to turn my timer on here. Besides being a community practitioner, I'm a minister and educator, and education and preaching conflict often. They're different forms of communication. So I'm going to certainly make sure I stick to the allocated time. Okay, let's see here. All right. So Sharrelle and Weyling and I and Dr. Johnson took our call very seriously, and I'm going to break this down in terms of the community practice angles. And so my subject is building health equity through the convergence of grassroots and professional communities and cultures. So I live in Robeson County. I want to ask you, you all probably know about Robeson County, particularly the negatives, the reputation of our county, but we also have many assets. Besides our racial diversity that most folks know about, we are also a very eco-diverse county. We're the largest county in North Carolina. We have 50 swamps and a river running through it. I actually wear many hats and actually have the only outfitter on the Lumbee Lumber River. It is home for the Lumbee, the largest Native American nation east of the Mississippi. It's also one of the poorest counties in North Carolina and the sixth poorest in the nation. Sharrelle commented on eastern North Carolina, and you saw how much of the poverty is in the east. It's not only the historical home of many of our African Americans, but also 4 of the 6 Native American Indian nations that are recognized by our state are also in the east. And so the convergence of indigenous and African American populations are a major reason for the poverty as well as distance from our urban areas, which means that many of our European American families are also poor. I won't go through all the data, but you can look at this list over here for Robeson County and our health factor rating and our health outcome rating, we've always been near the top or the bottom, whichever way you want to look at it in terms of the state. This particular study really gets at the issue of this panel and this conference. If you haven't seen this report, it's a very good report on racial and ethnic disparities in North Carolina. So to me, the greatest barrier to health and well-being, I'm going to posit, is creating equitable access to health and well-being are the barriers between these four characteristics: assumptions, values, principles, and practices of our professional communities, cultures, and cultures, and those of our grassroots communities and cultures. In spite of all the racial differences in our county, after 40 years of community practice, I'm convinced that the greatest barrier is not just race, but it's the cultural barriers between our professional culture and our grassroots culture. And these are particularly manifest in two systems: our healthcare system and our legal system. Now, you know, the challenge with characteristics is they can often become caricatures. But these two charts that I work with in many of my trainings sort of are made to show the distinct differences between these two cultures and their biases and their interests and their values. So on the community side, you've got grassroots interests. It really is, as we've said this morning, relationship-based. It's more process-oriented. And I particularly want to call your attention to this word, andragogy. It's not much understood. You may not even have heard it before. It's the contrast to pedagogy. Andragogy deals with the process of how we do things. The medical profession, as we've discussed, talks about product and what we do, but how we do for grassroots people is 60% of their motivation to participate in that system. Is how it's done to them most of the time and for them, not with them. And if I had more time, I would tell you that two of the barriers for me in healthcare are the waiting room and the examination room. And if I asked you, how many times do you go into the examination room and actually lay down on the examination table? My experience is 1 out of 10 times I go. So why do we even have them in the room? So those are the questions that I raise. I've been very engaged in the healthcare profession. I was born with a terminal heart disease, and going through that as a child and having surgery back when kids weren't even considered human has led to some serious understanding in my challenges with our healthcare system. So I want to acknowledge that both of our systems and cultures on the grassroots and professional level are dysfunctional. And when we come to the table to do with our health equity committees, we need to just start with that reality. So then when we talk about honesty and openness, we focus on honesty that heals and brings us together rather than honesty that harms. And we also have to realize that our greatest strengths are also our greatest weaknesses. One of my spiritual directors really helped me understand that. And I love this little cartoon, if you will. The longer you swim in a culture, the more invisible it becomes. Okay, so how are grassroots professional barriers manifest in the medical field? Well, it's mostly one-on-one case management, focus on productivity and efficiency. I don't need to go through this list. It's already been discussed this morning. But I just want to point out this last note. The word patient indicates a level of irony because it really means long-suffering and passive. So how do we converge our grassroots and professional cultures to advance health equity? I have a number of steps. I'm not going to go through them all. All these PowerPoints will be available. I want to just point out to this one. Meet on a regular basis. I'm working on a book on social action because practitioners that practice don't write and academics that write don't practice. So there's a major gap in our literature when it comes to all forms of social action, no matter how you do it or what your ideology is. There's a major lack of understanding. And when I've researched social action, every group that is serious about changing lives meets on a regular basis, once a week. And if you're not that serious about changing lives, you can't do it once a month. Whether it's Boy Scouts, Sunday school, Kiwanis, JCs, support groups. AA meets every night. That's the most clear example for me. So, and this is real important, to work together to identify the cultural barriers, dysfunctions, and challenges in both of our cultures. I was involved very deeply in the Robert Wood Johnson Opening Doors efforts in the 1990s, and really began to understand through our local project with a healthcare agency how difficult it is to talk about the dysfunctions in our own community culture, whether it's organizations or grassroots communities. And this is so important if we're really serious about assessing the barriers and solutions for health equity. Also, we really need to assess the relationship between our healthcare agency or system and our community partners and how it hinders and deters meaningful relationships. It's our healthcare providers, if you will, that have the power to invite and include our grassroots organizations and leaders into the room as equal partners. And then we need to work together to identify solutions to reduce and remove these barriers and create, as we've said today, meaningful relationships and engage our two cultures in healthcare, institutional and systems contexts working together to actually transform both. Also, we need to consider the use of groups of community care, communities of health program participants in your medical practice. And what I mean is I'm biased toward groups, not the individual care approach. Groups for grassroots people, they want, loneliness is a medical illness. And for grassroots people, when they hear the stories of other people who are going through the same challenges they're going through, they'll come back. But our no-show rate in our county is 50% with our health care providers, even though we have the largest Medicaid percentage and Medicare. Over 40% of our entire population is on Medicare, and with Medicaid it's close to 50%. In spite of that, and with private insurance, we still have a 50% no-show rate. Now this book, The Community Cure, Transforming Health Outcomes, is really a radical book. When you mean radical, means getting to the roots of how to work with grassroots people in a health context. The book promotes group meetings, and I'll show you a really wonderful quote. The medicine that happens in the room between patients when they're together. So this whole new approach called functional medicine really, to me, captures the essence of what grassroots community folk are looking for in all of our systems. Building relationships in community, peer-to-peer support models, peer-based learning modalities. If you're involved in the mental health profession at all, peer support specialists are now Medicaid reimbursement positions within that, and that was one of the major federal policy changes in mental health of using peer-to-peer support. We haven't used peer-to-peer support as most in our healthcare agencies. Now, in my theory of change, I'm working on these are the 9 levels that I have found. And when we're looking with the state, with North Carolina 360, to me, all of these levels of change need to be involved in that when you're looking at a community system. And if I were designing a local collaboration, I would make sure that all of the agents and agencies that work on these 9 levels of change are brought to the table. And my comment is, cultural change is actually not that different than individual change. We think it's more complex, but the same dynamics of power and various forms of influence and inside, within, and external forces outside the boundaries of our experience are basically the same. So it's not as complicated to transform culture as I think we imagine. Also, there's these 4 major types of change in my research, and I would just say that in terms of our healthcare profession, relief goes along with crisis and acute care, support goes along with chronic care, development goes along with preventive care, and transformation goes along with equal and equitable care, or what I would call just care. And all of the strategies that we use in the health and healthcare profession fit neatly under one of these 4 types of change. So what are my major learnings? My major learnings in addressing health equity are that to advance it, we really need this convergence and engagement of the clinic and the community as equal partners in identifying, removing, and overcoming barriers and challenges together. My proposal is, how often should they meet? Weekly, if you're really serious about it. Just to build relationships and build community. So when the challenges come, you have those relationships and community to fall back on. I don't like the word patients, I don't like the word client, I don't like the word consumer. I am a consumer in the mental health system because my son has chronic schizophrenia. I don't like being called a consumer. It sounds like you're there just to take. I don't think it's a better term than the legal term client. I particularly prefer program participants as a term rather than patient, client, or consumer. And in the group setting with functional medicine, I love this quote, you get your community support and medical care before you get sick in a group setting. So we have support groups, just like AA, just like we need diabetes support groups in a 10-mile radius of everyone living in eastern North Carolina. You do this before you get sick. You bring in your family members as well. A couple of the learnings, to create significant health equity involve relationships of accompaniment and empowerment. This is very staff intensive. I don't think our funders realize how staff intensive it is. In spite of, I've worked extensively with Blue Cross Blue Shield projects, with our regional food system and others. I think they understand it, but this type of accompaniment cannot be fulfilled in a conventional case management or crisis management role. Also, lastly, research indicates that health equity programs that engage and empower program participants and sustain groups optimize changes in behavior and health outcomes, advance participant leadership, equalize relationships of power between roles, reduce costs, and increase revenue for healthcare service providers. Thank you.
So you get an idea about how much fun I had working with this group to plan this. And I'm going to pull an audible. We're going to be done at 12:30 for lunch.
We'll extend it a little bit. Let's say 25 minutes.
Okay, 25 minutes. I see everybody frowning. No. And I'm going to pull a little bit of an audible and just, instead of me moderating and asking questions, just really would like to get the audience engaged. And it's just such rich work. I can tell you from an organization that's highly embedded in our community, as we alluded to a little bit in Ahoskie. We have a hospital in Bertie County. And if you've never watched the movie Raising Bertie, you need to watch it tonight. It is an incredibly impactful movie, but as we work as an organization to advance economic development, education, and health and well-being, you really have to, it's about community engagement and embedding in the community. And one of the one of y'all said something that just reminded me of a Yogi Berra quote that in theory, practice and theory are the same thing, but in practice they're not. And the only way to deal with this is just throw yourself at it and be in the community and have those meetings. And so I really appreciated that perspective and the insights that y'all brought. And so I have so many questions I could ask, but I would really just like either comments or questions. We'll open it up, but really input. Y'all are the professionals. Y'all live this every day, and part of this purpose is really to open up dialogue.
Good afternoon. I'm Chris Kohler from the Millbank Fund. I'll be on the panel, another panel later on. This is really interesting, especially for someone who works more at the national level. So thank you, all of you, for putting it together. I have a question for Mr. White. If we're about change and trying to improve things, make things better, using kind of the processes that Reverend Legerton talked about, you've dove in. You've got the political process, which is where change happens. Are you more optimistic about the political process for creating change than you were when you started? How's it going?
No, well, December 10th, I get sworn in. I think I'm completely transparent. So the process has been extremely difficult, but I'm very hopeful. One of the reasons why I think I was successful in winning this election, I didn't have an opponent, but a lot of people said, well, you're going to get a write-in because, just being frankly, the white people here don't want you to win. They don't want us to have a black mayor. But as I moved forward throughout the campaign, there was so much support from everyone, from both sides of the tracks. And I think that this win kind of personifies the removal of those railroad tracks a little bit, because I was born and raised in Ward B, grew up there, played basketball, did everything in Ward B, work in Ward A, lived there, collaborate with a lot of people there, and now we're going to both work on solutions and bring forth change to the entire community. So I'm very, very hopeful now. In the past, a lot of our mayors, I went to our town hall right after I won, and the town manager was like, I said, okay, so where's my space where I'm gonna, sit at? He said, oh, the mayor's never used the office. We use that as storage. And I was like, so I walked in the room, told you I'm transparent. I walked in the room and I opened it and I was like, okay, I'm thinking it's gonna be this little tiny closet, boxes up to here to the ceiling. There's so much room and there was little boxes around the wall. I was like, 3 desks can fit in here. What you mean it's a storage? This is like, we can work. And they said, no mayor has ever worked. So, yeah, we don't get paid. Yeah, so so I'm extremely. So you can see this hasn't really been really been serious and brought to the forefront in a lot of different. I've talked to the Rotarians, the Kiwanis Club, our recreation department, and a lot of people are like, we just want somebody that's going to speak for us, the entire organization. And so my platform has been around youth development, crime prevention, our infrastructure, and bringing small businesses, and of course working with our healthcare agencies to make us a more healthier. We have great clinical care in Hereford County. We have we're doing good with our amount of providers, diverse providers that we are bringing, but we just need that to translate into our health outcomes. So I'm very, very hopeful of where we're going.
Yeah, and I think as a follow-up question, I'll ask one. Just a little history in Ahoskie. I'm new to North Carolina, been here 4 years, but the hospital in Ahoskie was the first Hill-Burton hospital built, designed through the Hill-Burton Act, which is really an incredible historical thing, I think, reflecting on where the nation is, especially in rural America, and what is needed to deal with some of these issues. And then the community health center was spun out of the hospital and created from that hospital before it was a Vidant facility, or actually was a Vidant facility then. But so there's this really unbelievable collaborative and cooperation there. ECU, Brody School of Medicine, has a dental health clinic that's actually in the same facility that you saw, that's integrated with the FQHC there. So it's a really interesting and great model. And coming into that, you said something the other day that so you just talked about it from the cultural perspective, and Mac, I like your perspective. I mean, the also on this, but the you know, the community's perspective. But you said something the other day about the and you mentioned it here about educating and trying to bring down some of the internal organizational barriers. And I'll just tell a story, and I'd like you to comment about that, because you told a story. But actually, I was driving up here this morning, and we do a lot of, like a lot of us, you know, trying to open the mind of our institution and do, as you mentioned, we have a lot of programs. And I was talking to a group the other day about equity and inclusion, and it was a bunch of old white guys. And I was in the room, and I'm an old white guy. And I said that, you know, we gotta change that, right? And I used the term old white guy. On the way up here this morning, I was called at 7:10 saying we were offended by the fact that you used that term to us. So the whole white fragility issue kind of came right up at me, right? And I'm going, oh, really? Well, I didn't mean to offend you, but we do have to deal with that. But you had alluded to some of that. And could you just talk a little bit about that issue? And
by the way, White Fragility by Robin DiAngelo is a very good book if anybody wants to pick that up. But we've struggled with this issue for quite a while. And we've one of the things I think is and we actually talked about this Tuesday in our meeting in our health equity, is because we've been struggling with straddling the fence, making everybody comfortable. But this work is uncomfortable, and if you're going to have change, you're going to have to go through discomfort. And we made the decision Tuesday. Okay, are we going to continue to be safe, or we're going to, we all adults in here, are we going to piss some people off? And if we're going to bring change, we're going to have to be intentional about where we stand as an organization. We are not at the place where we're having a zero tolerance policy on discrimination just yet, but I've seen where other organizations have taken that on. So I think that's going to be an opportunity for us as well.
And I want to just comment that one of the definitions of structural racism that I often use is one by a physician and epidemiologist, Kamara Jones. And she says that it's a systematic, you know, the ways in which we systematically kind of create systems that benefit some individuals, disadvantage some individuals, but also sap the strength of the whole society, right? And I think in this conversation about structural racism and how it infuses itself or finds itself in different systems, whether it's through residential segregation or a healthcare system, we have to get to the conversation is like, this is bad for all of us, right? So this is not just impacting Black folks or indigenous folks or Hispanic folks. It's actually making it so that our state as a whole won't flourish and won't thrive, right? And so I think this conversation is really inspiring to see that folks, I think, are really willing to, like, let's wake up to this. Let's think about how do we take a structural racism lens, think about these systemic and historical things that have happened, and create the policies that actually move us all forward, right? And I do think that that's really necessary as we have these conversations. So we can say the word racism. It's okay. It's not going to kill us, but it is going to move us forward. I was actually at Greenleaf Christian Church with Ibram Kendi, who's written a book called How to Be an Anti-Racist. And he talks about racism in our country and our state as being a cancer. And when you find out the diagnosis of cancer, you're scared. You don't want to deal with it. You really don't want to confront it. But if you don't actually deal with the cancer, it'll kill you. And that's what we're seeing. We're seeing it in our health outcomes. We're seeing it in the ways that we're not thriving as a state and as a nation. And if we don't, in this country, deal with the issue of racism, we're not going to move the needle on equity in our state or in our nation.
I really appreciate those comments, because I think two follow-up comments is, one, that the issue is it'll kill us, but it's killing the people that are you know, at the margin, right? And so the voice, and actually that's what Jim was going to talk about, that Jim Johnson was going to give us the data on how we vote and the demographics on voting, and how we actually have to get people like me, older white men, and the demographic that I represent, to vote differently, or we are going to continue to have these structures, because the voice isn't there, and that's what was so glad to see what happened in the Hosky, but that's not going to happen at a state level. And so, Mac, do you have any comments about, you're an expert.
Well, we had a test. We had a, I think someone wanted to comment out here. I'll just lighten it up a little bit. You know, in rural areas, we have all these little adages of wisdom, and one of them is it takes a lot more energy to dig a hole than to fill it back up. And I think there's so much resistance to looking inside the holes that we don't realize when we come together and use our energy to fill that hole back up and use it to build on the foundation of the future, you know, and just let our guards down and trust, as was mentioned this morning, build those relationships of trust. I mean, we built a multiracial leadership team back in the 80s and 90s. I was the youngest in our county, and we just did amazing work together. Of course, 3 of us were ministers, and actually that helps. Sometimes it's a hindrance. But you know, focusing on the common interest and values that we have is really the key, and keep the focus there. Deal with the shadow side of our histories and our personalities, but let's get busy on creating and transforming these systems. There was a comment out here.
Yes, I have a comment and then a question for the whole panel. I'm Cedric Baker from Jamu, the food pharmacy. Jamu is a Bahasian Indonesian word that means plant-based health, and that's food with a PH and pharmacy with a F. So my first comment is the pictures of the train track so visually reinforces this phrase of other side of the tracks, or however you want to iterate that. And that the Wellness Center, using the example of Ward A and Ward B, the Wellness Center was in Ward A. The health disparities are overwhelmingly in Ward B, with heart disease, cancer, and type 2 diabetes. And cancer is already worldwide taking over heart disease as the leading cause of death. So when I was working in South Georgia and North Florida, I made a mobile wellness center, botanical wellness center, which was an RV that could literally drive over there and move some of the wellness to the Ward B, because a lot of those patients probably are walking and they don't want to cross the tracks for whatever reasons. So this is an important thing, is bringing the wellness to where the actual patients are that need it. And wellness, I must say, is fundamentally we're talking about prevention, whether it's primary, secondary, or tertiary. And that was brought out very well. And the last point I want to make is this word patient. Maybe we could use something else like self-care cooperatives or something along those lines. Anyway, I welcome your comments.
Well, I totally agree that, I mean, I think that one of our strategies is extending care to home or as close to home locally as you can. So, but there's huge challenges with that, but the community actually built that wellness center in Ahoskie, and you know the community leaders at that time chose that. Yeah, it's great. Oh, it's unbelievable asset. I mean, people really use it. But it is, I think, coming to the table and having the dialogue and coming up with solutions like that. And I think as we're here talking about policy and the intersection of policy and then community activism and engagement, you know, I think that we have to really, I find it interesting, I'll just tell you, and that's why I said watch Raising Bertie. You've lived that reality you describe. I was in Ahoskie last week and go to Bertie and all of our communities and meet with community leaders. Extending care to those environments or services is extremely difficult. And we can talk about Medicaid expansion, but it's not just Medicaid expansion. A hospital so your map, I loved your map. So you stopped in Rocky Mount, and in Martin County, which is 30 miles down the road, 25, they just closed OB services in that hospital in a part of the country that has one of the highest, if not the highest, infant mortality and maternal mortality, which primarily is 10 times higher in African American women than Caucasian women. And it's low volume services. And so that institution couldn't carry that burden with less than one birth a day. But when you close that service, more women die and more babies die. We have one baby a day in a hosky, but if we're not there, a mother and a child has to drive over an hour to get prenatal care or to deliver their baby. And so those are real structural issues that I think we have to understand in the second largest rural population in the country, 4.3 million people, that we have to have policy and payer alignment around that and extend other services as close to home as we can. One more?
This panel is amazing. I'm just totally humbled to be here learning from you all. So I'm Cal B. Brown. I'm a medical student at Duke. Grew up in a very conservative world. Now I, come back to the people that raised me with, an elite name next to my name, an advanced degree. I haven't completed yet, but right. Being in Durham for 9 years, it's for better or worse, almost cool to be able to talk about systemic racism and inequity. It's such a culture where you're allowed to engage this, and there's people advocating at every corner that you can join in. But as I'm sure many of you know, when you bring this back to the people who don't have the same shared experience as me, there's defensiveness always, as was mentioned earlier, but there's also a sense of being looked down upon from the elite sort of tower of knowledge. And I'm so convinced by data. I can read a chart in 2 seconds, and I get the point. But presenting the research that we're doing at these institutions, I feel like is really hard to tell the story and to get that point across. How have you all found that you're able to bridge that gap with just a larger society?
I'll make just a quick comment. I get asked a lot of questions in rural eastern North Carolina. Well, you're a minister, but what's your perspective on life? How do you identify myself? And I think the key to opening access, to inviting people in, is to be professionals with a grassroots perspective. All of our formal education, pushes us to be professionals with a professional perspective. And actually, that sort of elitism sort of just filters in through osmosis. It teaches us to be disembodied ourselves, to be head instead of heart, like the chart. And we end up being divided within ourselves, much less with other people. So I really think I feel so privileged to be an organizer and work in a rural community that is so distressed and oppressed and neglected. I feel privileged because my first commitment is to transform myself. And this thing keeps going off every 10 minutes. So maybe that's a signal. It's time for lunch. But to me, that's the thing. We need to be professionals and really struggle and be challenged to develop a grassroots perspective and really open to what it means to see our relationship with everyone in the community, no matter what context we're in, as the most important privilege that we have, is to develop meaningful relationships with each other.
Great way to end. Thank you all.
It was indeed. It was a great way to end, but it was a great way to course throughout the conversation. Really an extraordinary morning, an extraordinary beginning to our discussions, and an extraordinary affirmation of why it's so important for us to start our engagement with local and state issues here in North Carolina. It's hard to imagine a place which is a stronger crucible of the combination of opportunity, vision, understanding, and challenge. But the thing that came through for me personally throughout the course of the conversation was that understanding dimension, which is a starting point for everything. And we look forward to building on the understanding that's been shared by each of our panelists throughout the morning and carried into the afternoon. We now have, let's see, we've got, we'll be back here, we'll take 45 minutes for lunch. Does that work for everybody? And we'll be back here to start at 1:20. So we're breaking for 45 minutes. Lunch will be served in the Glaxo Galleria, which is the main lobby. Glaxo Galleria. I think we must have gone back to the other side of the tracks. Tables are set up in the dogwood and congressional rooms for lunch. And be back at 1:20, and we're going to start with investing in whole person health. Thank you all very much.